All right, guys, welcome back to Underground Science. In this video, we'll be talking about Bernard-Soulier syndrome, okay? I hope I'm not pronouncing that really wrong, okay? But we're going to be talking about Bernard-Soulier syndrome, okay? So let's go and get started. So if we talk about the basic pathophysiology, right? Start with the genetics first, which is this disease is autosomal recessive, all right? So you need two mutated copies in order to get this disease, right? One from your mom and one from your dad. Okay, so what happens in this disease, right? In Bernard-Soulier syndrome, what happens is you get a defect in your glycoprotein 1b protein, right? So if we remember, if you have your endothelial lining right here, let's say, right, and you get some sort of endothelial injury, right, that exposes your subendothelial collagen, and then you get von Willebrand factor that binds on your subendothelial collagen, and then platelets come in, try to make a clot, right? So you don't keep on bleeding out. You get your platelets that bind to your von Willebrand factor, and this protein that they use to bind to the von Willebrand factor is glycoprotein 1b. All right. So this protein, though, is defective now, right? It's either absent or it's defective. So that means that you can no longer have platelet adhesion, right? So platelet adhesion no longer works because you don't have functioning glycoprotein 1b. So you can't adhere onto the von Willebrand factor. All right. So you have impaired primary hemostasis, right? Remember, in this, the goal of primary hemostasis is to form a weak platelet plug. Okay, but this is impaired now because glycoprotein 1b doesn't work, so you can't even do platelet adhesion, right? And if your platelets cannot adhere properly to von Willebrand factor, then that will lead to decreased platelet aggregation, right? Because you need platelet adhesion to work first, then platelets get activated, and then platelets aggregate. But you can't even, if you can't even adhere properly in the first place, then obviously it makes sense that you're going to have decreased platelet aggregation. So right away, we can know that, okay, we may see an increase in bleeding time in this disease, right? Because you can't clot properly because your primary hemostasis is impaired. So what will we find in labs, right? Turns out you actually find large platelets, okay, on blood smear. So you have large platelets in blood smear. That's important to know, okay? That's a clue. And of course, if you're so when we're talking about certain things like ITP, TTP, HUS, right? We encountered thrombocytopenia, but that's like true thrombocytopenia, right? Like really low platelet levels. But in Bernard-Soulier syndrome, you do have thrombocytopenia, but it's mild. Okay, so you can see thrombocytopenia, but it'll be mild. Okay, and it's a little out of order, but if you have thrombocytopenia, then you can. eh, But that's not the primary reason, though, right? If you have thrombocytopenia, that's mild. But on top of that, remember, glycoprotein 1b is defective or absent, so you can't do platelet adhesion. Therefore, you cannot properly do primary hemostasis, so you can't form a weak platelet plug. So you may see things like skin and mucosal bleeding, okay, which is the classic feature that we see when platelet adhesion doesn't work, right? If your platelets in general don't work, then you can see things like skin and mucosal bleeding. All right, so that's something to keep in mind is that you don't only see this if you have major thrombocytopenia like an ITP, TTP, HUS, right? You can also see skin and mucosal bleeding due to certain mutations leading to impaired primary hemostasis. Even though your platelet count is normal to mild, you can still see skin and mucosal bleeding because your platelets themselves don't work properly because they can't adhere to von Willebrand factor, therefore they can't stop bleeding properly. So your bleeding time will be elevated also. But nowhere here did we talk about nowhere here did we talk about dysfunctional coagulation factors, right? Remember, PT measures your extrinsic pathway, so including factors 3 and 7, and PTT measures your intrinsic pathway like 12, 11, 9, and 8. But nowhere here did we talk about dysfunctional coagulation factors. So that means your PT and PTT are normal, okay? So you see large platelets, normal to mild thrombocytopenia, dysfunctional glycoprotein 1b, so you see skin and mucosal bleeding because you have impaired primary hemostasis and platelet adhesion. And because of the dysfunctional platelets, right, you have increase in bleeding time. Okay. Now, the last thing we should talk about is the ristocetin test. So, what is ristocetin? Ristocetin is an antibiotic that you can that is used in lab testing. What it does is it forces, what does it do? It forces von Willebrand factor to bind, right? It forces von Willebrand factor to bind onto what? Glycoprotein 1b. Now, in Bernard-Soulier syndrome, we just said you have dysfunctional or no glycoprotein 1b due to a certain autosomal recessive mutation. Well, if you don't have glycoprotein 1b, or if you do, but it's dysfunctional, then how will von Willebrand factor bind to glycoprotein 1b if there's no glycoprotein 1b to bind to, right? Or if it's defective. So, so then that means that we won't have von Willebrand factor binding onto platelets, specifically glycoprotein 1b. So normally, if you did the ristocetin test, you would see ristocetin-induced agglutination, right? So you would see ristocetin-induced agglutination or aggregation, right? Whichever wording. So, and normally, right? Normally, if you put ristocetin into this patient's blood, right? Then you would see von Willebrand factor binding onto glycoprotein 1b. So this would you would have a positive ristocetin. You would see ristocetin-induced aggregation, right, or agglutination. And what do I mean by agglutination? Von Willebrand factor would bind onto platelets because they have that glycoprotein 1b to bind onto in a normal patient. But if you have Bernard-Soulier syndrome, you have dysfunctional, defective, or absent glycoprotein 1b. So in these patients, if in Bernard-Soulier syndrome, if you gave ristocetin, right, then of course you can expect, right, we'll wrote it up here, that you would not get ristocetin-induced aggregation, or you would get absent ristocetin-induced aggregation, right, reduced or absent. And the reason being, again, is because von Willebrand factor has nothing to bind to. They don't have a functional glycoprotein 1b on the platelets to bind to. So you wouldn't get any aggregation or agglutination. And by aggregation agglutination, we mean von Willebrand factor binding onto your platelets, specifically your glycoprotein 1b. So if they bind, you get agglutination. If they don't bind, you don't get agglutination. Here we wouldn't get agglutination because we don't have functional glycoprotein 1b. Okay. But then you can ask, okay, so in Bernard-Soulier syndrome, you get reduced or absent ristocetin induced agglutination, right? But then how do we differentiate this from von Willebrand disease, which we'll talk about right soon in another video? But how do we differentiate? Because here in von Willebrand disease, right, just to quickly state, you don't have von Willebrand factor, right? You have dysfunctional or low von Willebrand factor. So if you have dysfunctional or low von Willebrand factor, then that means you don't have sufficient von Willebrand factor to bind onto your glycoprotein 1b 2a or glycoprotein 1b, excuse me, right? So then in people with von Willebrand disease, if you did the ristocetin test, remember what does ristocetin do? It forces von Willebrand factor to bind onto your platelets by binding onto the glycoprotein 1b. Okay. But in von Willebrand disease, you have dysfunctional or defective or very low amounts of von Willebrand factor. So you can't have any agglutination or aggregation. All right. Because you don't have much at all of von Willebrand factor to bind to glycoprotein 1b on your platelets. So here you would also see your ristocetin induced agglutination would be really low or absent. So this would also be low to absent. So then we see the same thing, same result in Bernard-Soulier syndrome and von Willebrand disease. So how do we differentiate between these two? You would have to do a mixing study, okay? So let's see what happens there. So in a mixing study, you would take this patient's blood. So let's say you have a patient with Bernard-Soulier syndrome and you took their blood or their plasma, right? And you mixed it with normal plasma. Well, normal plasma should have normal von Willebrand factor, right? So if you took, so we'll represent uh, plasma belonging to a Bernard-Soulier patient as blue, right? So if you took plasma from a Bernard-Soulier patient who has defective glycoprotein 1b, right? But it's not like they have a dysfunctional or very low amounts of von Willebrand factor. They have normal of that, right? Normal von Willebrand factor, but they don't have glycoprotein 1b. So that's theirs. And then if we took a normal patient, or if we took the plasma of a normal patient, right, and mixed them together, what is that going to do? Well, a plasma of a normal patient has normal amounts of von Willebrand factor, but so does patients with Bernard-Soulier syndrome, right? So do patients with Bernard-Soulier syndrome. Okay, so then you have von Willebrand factor from a normal patient who doesn't have Bernard-Soulier, and you have von Willebrand factor from a patient who does have Bernard-Soulier, right? But the thing is that when you mix the plasma of a normal patient and Bernard-Soulier patient, you still don't get ristocetin-induced agglutination because the problem isn't that you don't have von Willebrand factor, it's that the platelets on the Bernard-Soulier patient don't have glycoprotein 1b. So no matter how much von Willebrand factor you have, the platelets, right, don't have glycoprotein 1b. So even though you add ristocetin, then no matter how much more von Willebrand factor you have after mixing, right, after the mixing study, you don't have glycoprotein 1b to bind to. So in Bernard-Soulier syndrome, when you mix their plasma with normal plasma, right? All you're doing is just you're just adding the total, you're just increasing the total amount of von Willebrand factor. You're not fixing the fact that you're not fixing the glycoprotein 1b on the platelets. So the ristocetin induced, now if you do the ristocetin induced ristocetin test on this mixed plasma, right? So then would you see ristocetin induced agglutination? No, right? You still wouldn't see it. So this would still be reduced or absent. So that's how you can differentiate, right, between Bernard-Soulier and von Willebrand disease. Because in von Willebrand disease, right, so if we have a von Willebrand disease plasma, or if we have a patient with von Willebrand disease and we take their plasma, which will represent in the red color, and then if we have a normal patient, right, and we represent them in this yellow color, right, take their plasma, we mix these two plasmas, right? So we take the normal patient's plasma and we mix it into the plasma of the patient with von Willebrand disease. What will we see? So in von Willebrand disease, you barely have any von Willebrand factor or any functional von Willebrand factor. So the ristocetin-induced agglutination test would still be reduced and absent, right? Would be reduced and absent in patients with von Willebrand disease because you don't have any von Willebrand factor to bind to glycoprotein 1b. However, if you mix a normal patient's plasma into the plasma of a patient with von Willebrand's disease, now you're giving the plasma, right, belonging to the patient with von Willebrand disease, you're giving that plasma von Willebrand factor, normal von Willebrand factor. Okay, so from the normal patient's plasma, you're getting von Willebrand factor now. That's functional. And in people with von Willebrand disease, there was no problem, remember, with the glycoprotein 1b, on the platelets. And then you just mix normal plasma, right? So now the plasma, right, has von Willebrand factor. So now if you give ristocetin, you have von Willebrand factor, functional von Willebrand factor, and enough to bind and agglutinate, right? So it can bind onto the glycoprotein 1b. So then if you did the ristocetin test, right, you would see ricin agglutination, ricin-induced agglutination, all right? So that you would see this. So it'd be restored. So this is how you differentiate between von Willebrand disease and Bernard-Soulier, okay? So I know that was probably a too long of explanation. Sorry about that, but those are the main findings for Bernard-Soulier. I hope this video wasn't too confusing. I hope it made sense. I hope you guys learned a little bit. Thank you guys for watching and see you guys in my future videos.